For the next talk, I would like to invite Professor Dr. Thomas BUDDE for your talk in pulmonary embolism, update 2021. Please, Dr. BUDDE.
Good morning, everybody. It's my pleasure to be with you. I hope you can see my presentation.
Yeah. Show you.
At the moment, I don't have it on the screen, but I have a look. You have my presentation?
No, we cannot see your presentation. Cannot see.
Auf den Präsentationsmodus am besten drücken.
Here we are.
Ja. Genau, perfekt.
Everything is fine now? Yeah. You can hear me, you can see me. So, good morning, Mr. Chairman, our friends in Vietnam and our friends here over Germany. My talk is on pulmonary embolism, and it's a pleasure to be with you this morning. I brought first two cases of pulmonary embolism, which is the first one here. This one was a patient in very stable condition. It was just an almost accidental finding. You see here the emboli in the pulmonary arteries, and he just had a little bit of syncope, a short syncope and some dizziness, and that's it. And we did only detect it by doing the D-dimers. This is another case I did some 30 years ago already, when I was still at University Münster. And you see at that time they did invasive angiograms, and this patient was in shock. What you can see here is that the pulmonary arteries on the right side are almost completely closed. And if you see, if you see here, you see what we call amputated heli on both sides, and at least on the right side at the lower part of the image. So what about pulmonary embolism in nowadays? In these countries here, this is a comprehensive data collection. We have an increase of the annual incidence. It's not clear whether it's better detection or just really more incidence, but in hospital lethality is going down in all the countries. That means people have become more aware to everything. Nevertheless, pulmonary embolism is difficult to diagnose, and this is why our journal, our German journal, said it's like a chameleon. If you have autopsy causes, then you have 12 to 15% of the patients who die very quickly, and it has been pulmonary embolism. Of course, we have strong risk factors. You can see here the most prominent of them. Most of them are well known, but also I wouldn't have expected that. That is the newest version, that hospitalization for atrial fibrillation and flutter, or electrophysiologists have to know that, within the last 3 months is a strong risk factor. One would say we can describe it by looking for the symptoms, as we always say, if we do examination of patients, but it's a big problem. This clinical signs and symptoms may be misleading, because this is a group of patients. The left side, it's PE confirmed, pulmonary embolism confirmed, and not confirmed. And you see there's not so much difference between the two of them. So the symptoms do not guide us the right way all the time. Another important factor, or two other important factors are, and I did not know that before diving deeper into that, if you take the patients who come to an emergency room just for syncope, every 6 of the patients will have as an underlying disease pulmonary embolism. I think that is something very important to learn, that people who come for a syncope have very often pulmonary embolism. The diagnosis is very early if the patients have thoracic pain, prayers, or lower limb thrombosis, but it's very late if they already had dyspnea before, because it's masked. You can approach, if you don't have good symptoms, you have to use scores, and I'm sure you know the BEL score, which is formed by some clinical signs, which are summarized here. The risk estimation, if you have a proven pulmonary embolism, there are high, intermediate, or low risk. The most important is if the patient is hemodynamic unstable, then it's the highest risk factor you can ever have. And there are some other clinical parameters. I will show you this score in a moment. And the RV dysfunction is very important. So the bedside echocardiogram is of crucial importance, especially in patients who are at high risk. And the troponin is also a useful mean. This score is additionally evaluating the risk if you have proven pulmonary embolism, high age, of course, cancer, and so on, high blood pressure. What are the recommendations for diagnosis? We screen, and number one means that is very clear-cut indication to perform these measures. And what is listed here is that if you have hemodynamic instability, you should use a bedside echo in any case. And what is even more important, if you have the idea or proven pulmonary embolism, then you should anticoagulate immediately. The danger to anticoagulate somebody who does not need it is not as high as the danger to not do it. This holds true for hemodynamic instability or without hemodynamic instability. If you don't have hemodynamic instability, then you may use criteria for diagnosis like scoring systems or so on. And of course, the clinical evaluation is useful. How about the D-dimers? They are often used to say if they are low or if there are no, then it's not a problem, everything is fine. First of all, we have to say that 2 to 5%, depending on the test, may be false negative. And the other thing is that the D-dimers are only useful, and that is very important, with low or intermediate clinical probability. If you have high probability, they are not of any use. So negative D-dimers with high probability in clinical science should not exclude further evaluation. The CTPA, CT, pulmonary angiography, this can be used to exclude or to definitely prove pulmonary embolism. Thus, it's a very useful tool. The scintigraphy, to my opinion, it's not so important any longer. Also, the availability is not so very good. But if you don't have CT or scintigraphy, that is a very useful tool. You have to do a compression ultrasound of the lower limb. This, however, may be sometimes difficult if you don't have anybody on duty who is able to do it very qualified. That depends on the examiner very much. So what to do? We have first to decide, we have to decide once again between patients with instability and stability and suspected, not proven, suspected pulmonary embolism. We saw before that hemodynamic instability requires bedside transthoracic echocardiogram. You look after the right ventricle. You see the red dots mark the most important points of this algorithm. You can follow them in the following images also. And then the question is, do you have CT or don't? If you don't, then you have to treat like high-risk pulmonary embolism. And if you do, you should do. And if you see there is no, if you see there is no pulmonary embolism, then you have to search for other causes. If you have a patient with suspected pulmonary embolism without hemodynamic instability, then it's useful, as we saw before, to do the D-dimers. And in this case, once again, in intermediate or low probability from the beginning, they are very useful. What is the management? What should we do? We are now sure. In this case, we have a patient with acute pulmonary embolism. First of all, anticoagulate. It's the most important determinant of survival, how early anticoagulation is initiated. No other thing is as important as the time until first anticoagulation. Then, if you did that, you did the best in the beginning. Hemodynamic instability, if it's not unstable, if it's stable, you have to reperfuse. We see that in the moment. And then we have to see, are there clinical signs of severity or serious comorbidity, or are they not? And if then you can at least divide it in high risk, intermediate, and low risk. And the therapy depends on that. If we have the high-risk situation, reperfusion treatment immediately. If intermediate, monitoring, hospitalization, and if low risk, and there is no other reason for hospitalization or other problems, then you should think of at least to send the patient home. Reperfusion, the thrombolytic therapy, is in any case indicated if you have a patient in unstable condition, no doubt. Then you see once again what to do. Immediate anticoagulation, if you do that parenterally, then you have low molecular heparin or fondaparinux is recommended, and if you start oral, NOACs are the method of choice. If you try to take coumarin or so on, then this is the range to go to. These are some special conditions. I won't go into details because my time will not allow this. We have situations in whom after 3 months is recommended, and then we have patients who should have longer than 3 months. These are patients which have recurrent venous thrombosis and so on in the history. And what is more important even now is the people noticed that the follow-up is very important because it's very risky sometimes. There are some special indications. I can go into that also because the time is very short. Pulmonary embolism in patients with cancer and in pregnancy. I just had a lecture on that for 1 hour. It's many aspects to be covered, but you see it's only category 2 recommendation. So what are other important aspects? There was a good review in the British Medical Journal. It's not very long ago, in 2020, in the second half of 2020, and there are some questions still be raised. The one important I already mentioned is that if you sometimes or anytime interrupt the anticoagulation treatment, it's maybe risky, and you have to identify the patients who are at risk by factors which are related to recurrent thrombosis in the history or cancer or so on. And if you look here, this is the interval after anticoagulation stopped after pulmonary embolism, and the rate of venous thrombosis or pulmonary embolism, you see here, recurrent venous thrombosis and recurrent pulmonary embolism, and you see after 1 year and going up to 10 years, there is a remarkable rate of relapses, including the danger which is combined to that. So we should keep attention on that, and we should not think the patient has left the hospital after pulmonary embolism, the patient survived, everything is fine. No, it's a long time caring for him and it is for her, and it is very necessary. It's also important, more and more important, what was the event underlying? Was a provoking factor which is transient? Let's say somebody drove by his car 20 hours, then and no other risk factors, then 3 months of anticoagulation will do. If there is no provocative index which shows something was a special situation, then you should look for these reasons: women at low risk and women at high risk, bleeding disorders and so on. And then you have to decide either from clinical factors or at least 3 to 6 months. And this is very important because cancer-associated thrombosis and pulmonary embolism is quite frequent. 6 months or as long as cancer is active. That is a very important thing. And this is my last slide. The questions which have to be still clarified is if you use the clinical probability score and D-dimer testing, can that be optimized in subgroup of patients who have a previous pulmonary embolism or in pregnant women, because they have sometimes or almost always elevated D-dimers. And another question is, what do we do with the patients who have pulmonary emboli, which are in subsegmental pulmonary arteries, which often miss the detection? And how can we manage the long-term following diseases of pulmonary embolism? Because there are some, for example, chronic thromboembolic hypertension. It's maybe a matter of surgery, but it's a very high risk and very difficult surgery, and the post-pulmonary embolism syndrome. Thank you very much. That is the word, German word meaning thank you, danke, and it was my pleasure to speak to you. Thank you so much.
Thank you, Professor Thomas Bodo, for your excellent overview of this very broad disease that affects our daily practice frequently. I think Wolfgang Feske has a short question to you.
Hello, Wolfgang.
Good morning. I just apologize to Mr. Okay, you can hear me? Wonderful.
I hear you.
I'm very happy to be part of the German-Vietnamese meeting again, but the question of pulmonary embolism, even without very impressive symptoms, is today COVID-19 infections. What is your strategy in those patients who have survived COVID infection without symptoms? Do you do routinely pulmonary angiography, or what is your strategy? We see a lot of pulmonary embolism in these patients who are suffering a little bit of dyspnea months after the infection.
I would not go so far to say in all of patients, but I agree with you. There are some well-documented data. Essen University has 250 post-COVID patients, and in Bonn they published also, I'm sure you knew, that some thousands patients with that. In any case of persisting dyspnea at the moment, I would go and exclude pulmonary embolism. Whether it may be echo for the right ventricle. If you do angiogram all the time, that should be in a study, I think, because it's contrast and X-ray. But to my clinical opinion, I think pulmonary embolism is so often overseen that I gave the motto in our hospital: if somebody has dyspnea, please prove it's no pulmonary embolism.
Are there any questions?
Nein, ich bin stumm geschaltet.
So, okay. Thank you very much. Now I want to introduce the next speaker. The next speaker is